For those of you who don't, I'd like to introduce you to Dr. Alison Dougall. Alison is president of the International Association for Disability and Oral Health. The IADH are a group of people who are concerned about those with disabilities and disadvantages, working together with those in the community, professional society, social and service organisation to improve oral health and quality of life for persons with special needs. It's an association that is doing a tremendous amount of work and something that I know Alison is incredibly proud of, and rightly so. So we're delighted to have someone of Alison's calibre speaking on our webinar tonight. One small bit of housekeeping, if you don't mind, is that if anyone has a question, please type the questions into the question box on the GoToWebinar toolbar. Alison, feel free to answer whenever works for you, during or after, whatever works. If there are any questions that we don't have time to get to this evening, we will gather them up and send out an email in the coming days with all answers to all attendees. So thanks for taking the time to log on this evening. I'm now going to pass you over to Alison, who will take you through her presentation.
Hi everyone. Can you see my screen? Is that working okay? Yeah.
That's working perfectly, okay. Alison. Yeah.
Brilliant. Okay, thank you. Thank you very much to PAMEX for inviting me, and hope you're all sitting comfortably, and we'll begin. So I have a particular interest in people with bleeding disorders. It's my research interest. It's something I've got very involved in since I came to Ireland, and that's going to be the focus of my talk today. But I'm also very, very passionate about inequality. And I work with people with disabilities, and by definition, often they're subject to lots of health inequalities. But I'm going to talk about an inequality within an inequality, because we're talking about an underserved group at the moment, which is women with bleeding disorders. So why are they underserved? Why am I talking about that today? Well, I think in reality, and I mean, I was taught the same. I think textbooks, teaching, the training that we had meant that when we talked about bleeding disorders, we always talked about haemophilia. It's the most well-known. It's probably the most glamorous. It's a very sort of difficult condition to live with, but it has a lot of file out there, and very strong, very empowered people with haemophilia from the patient community who have really pushed for services for their members. It's an exciting area. Lots of things are happening at the moment, gene therapy, lots of new ways of treating this disorder. But women are within this community as well. But I was taught, maybe you were too, that haemophilia or bleeding disorders were inherited genetic condition that were carried or passed through the generations by women and expressed by men. So when we talk about people with women with bleeding disorders, it's generally been where women were the parents of somebody, the mother of somebody with a bleeding disorder, or for example was the carrier, feeling guilty about passing that condition on. And so I think that somewhere along the line the woman got lost, and I think that we were in the belief that bleeding disorders only affected men. What we found, certainly within haemophilia, is that some women who carry the gene, especially who carry the severe form of the gene, actually live with quite severe symptoms themselves, and live sometimes their whole life, or certainly late to adults, without being diagnosed. The symptoms in women are plentiful, but I'm going to talk today about specifically that bleeding disorders aren't only about for boys, that girls bleed too. And I'm going to do some myth busting. I'm looking forward to some questions as we go along. So please feel free to write them in. I'll either answer them as I go along or answer at the end. So although women are affected by haemophilia, in fact, some are now so affected by haemophilia that the carriers, they've been re-diagnosed as mild haemophilia, some even severe. But the major bleeding disorder that affects women equally, let's not use that word equal, I'll come back to that, is this condition called von Willebrand's disorder. Now, this is an autosomal dominant condition. So that means that men and women can express it, and it's more common. So it's about 1 in 1,000 of our population, affects males and females. It's always been in the past considered less serious, in that seriousness was judged by whether people had brain bleeds or bleeds into their joints, for example. But this, rather than having muscular or deep bleeding, this condition is characterized by mucosal bleeding, nosebleeds, heavy periods, GI bleeds, bleeds in stools. Gum bleeding was often written as one of the symptoms. Things like easy bruising, bleeding after surgery or after childbirth. So straight away, we've been talking about this a lot in COVID. It's not a COVID talk, and I'm trying to keep away from this so that we're doing something different. But I wrote an editorial a few months about living in the times that we're in at the moment, where we're all in the same storm, but we're not in the same boat, as in we've got lots of other things that make this condition worse or make living in this time worse. And I think that this is not a disorder that affects men equally with women, because as far as I know, or certainly for most, gender's a difficult one at the moment. I don't get myself into trouble, but a disorder that is characterized by heavy periods or bleeding after childbirth is going to more impact on someone who identifies as a woman or has periods or gives birth to children, let's say. So let's talk about von Willebrand's, because some people have never heard of it, or certainly if they have, it's never talked about very much. So the first thing is that if you were taught von Willebrand's disease, it's lost the disease. The first thing is, this is about nomenclature. This is not a disease. It's caused by the defect of von Willebrand factor. And von Willebrand factor is a very large specialized protein. It was discovered a long time ago by a Swedish guy, 1926. What this does is it stabilizes and binds to the clotting factors that are involved in stopping us bleeding and stops them being broken down. So it means that it means it facilitates them. It also helps the platelets that plug up any damage that we have to an injury or a vessel wall. It helps them bind and stick together. It also carries some of the clotting factors to the site of the injury. So it basically facilitates so many areas of the clotting that will plug up a wound and stop things happening. So you can see here that it's stored in the endothelial cells, it's stored in the walls of the blood vessels, ready to come into action, bring the clotting factors in and start to get that wound plugged up so that the blood doesn't spill out. So why are we here talking about it? Well, I think knowledge is power, and I think that certainly there's been a lot of history of people being scared to treat people with bleeding disorders. So I'm hoping that because you're here, you're actually wanting to find out, because lots of dentists, the minute somebody says, or hygienists, that somebody has a bleeding disorder, the first thing they want to do is exit, or the patient exit. So I think that the way to lose that fear is to learn about something and to know where to go and what to do. I also want very much today, and the focus is to signpost and support women in getting a diagnosis and understand the beliefs and the barriers to that. We're dental teams, so we're not here to diagnose people, we're here to help with diagnosis. Our job is to promote good oral health behaviours, but to do that, we've also got to understand the beliefs and the behaviours of this group to try and stop this gum bleeding, which is so often talked about or listed in textbooks. I'm going to talk a little bit about risk assessing and providing safe care. So if we do need to provide care for patients, we're going to be the people who say yes and help facilitate their care, and a little bit about interdisciplinary working. So what's the motivation here? Well, if we look at the population in Ireland and we look at how many people should have this condition, we realise that there's about 2,500 women in this country who haven't got a diagnosis. And what does it mean about having a diagnosis? We hear about lots of people with autism wanting a diagnosis because it helps them get the support they need, or people with dementia really not wanting a diagnosis or feeling stigmatized by diagnosis. But what does it mean not having a diagnosis when you're a woman with a bleeding disorder? Well, it means that your condition is not managed and you're not living the life that you could be leading. What it shows is that where we talk about heavy periods, people with von Willebrand's, about 73% of people with von Willebrand's have really heavy periods. So we write this, we hear in the textbooks. I've been shocked when I've done a lot of the work that I've done with women with disorders to actually find out what this really means. It means that they're disabled really sometime for more than a week, not being able to leave the house, not being able to do sports. It means that the blood loss means that they suffer from anemia, really low. Anemia to mean that they're fatigued, they need to come in from work and go straight to bed, or they're, feeling very low. It means lost time from school or work. It actually is more serious. Well, it's not, can something be more serious than that? It means lower educational outcomes, lots of evidence to say people will leave school earlier, or they're too tired to study, or they've missed school. Reduced social interaction, or the ability to play sport, for example, affects their relationships with, quite severe bleeding after sex, leading to reduced self-esteem, reduce clothing choices, trying to cover up bruises on their arms or legs so they can't wear the sort of skirts that maybe they want to be wearing. Chronic pain, difficulty in conceiving children. About 40 to 70% of people with postpartum hemorrhage have von Willebrand's disease, and all these bleeding conditions that we kind of have to a certain extent trivialized have often meant women have early hysterectomies, for example, to try and cope with this condition. So why is it undiagnosed? Well, it's multifactorial, and this is where I think we can perhaps help, or certainly we can start to change our thoughts process, and as part of our medical profession, perhaps even advocate or run campaigns if we're running, if we've got that ability, because it's attitudes of society. What I've just talked about in many countries is completely taboo to talk about menstruation or periods or things. So people don't tend to talk, or certainly brush it under the carpet, maybe embarrassed. Then there's attitudes. If people do then address that with a medical professional, it's kind of sometimes, sadly, even with women, trivialized. With women doctors. So I think, or it's not taken seriously, or it's kind of not prioritized. I think attitudes of family, this is really interesting, because as this passes through families, it means that there is this is a completely disrupted idea of what's normal. So, for example, I think that the normal would be shared within the family. So if a woman is saying my periods are lasting for a week, then, oh yes, well, so's your mother's, so's your auntie's, so's your sister's. So for that family who perhaps don't talk with other people, that's normal. For somebody who is suffering bruising or is a bleeder, that's normal, and that's kind of just part of the family. So it kind of gets lost, and then perhaps the stoicism, or perhaps the fact that postpartum hemorrhage happens after an event with a baby, it carries on, and the happiness of the baby means that the trauma is perhaps brushed under the carpet at that point. Why is it undiagnosed? It's also undiagnosed because it's difficult to diagnose. Lots of women around the world have been not diagnosed because there isn't labs to do it, or the specialization, or they've got the wrong diagnosis. And even in a country which is known to be the leader in one of the leaders, I can't say the leader, I have to say one of the leaders, but really, really strong in this area. It can take 6 to 12 months to get the correct diagnosis, because there's lots of different types of diagnosis. You have to go through lots of tests and lots of functional tests. So it's not as easy as haemophilia, which is literally just a lack of something. This is very, very specialized tests. And so when is it diagnosed? It's diagnosed sometimes after surgery. Sometimes women can be in adulthood and they have their gallbladders removed and huge internal bleeding. It can be when a family member is diagnosed, and then, you know, perhaps some of the family start to get tested. It's much more now de rigueur. When this happens and people are diagnosed, there's always, in nearly 70% cases, there was previous dental surgery where they had teeth out as children and bled. Nothing was really done about it. And now they're kind of making sense of the past. Oh, yes, of course, when I had my teeth out, it bled. Or I had my teeth cleaned, really deep cleaning, and I bled for 5 days, but they didn't do anything about it. And I think this is often associated with blame of dental staff. They were heavy-handed. People don't like us anyway, but I think that perhaps sometimes there's blame there. But sometimes we don't address it either, because we feel bad if there's somebody blamed. We don't want somebody to have bled. And I think this is something I want to talk about today, really, because I think we need to reframe this, because if we help people or identify a bleeding issue and we stand face to face and accompany our patient in their kind of realization, then I think we can stop them from having a potential fatality if the next time that they need surgery, it's a cardiac operation, or they have an accident, or they're wanting to get pregnant, for example. So I think it's really important that we reframe and get rid of this blame out of here. So I think signposting patients is really, really important to us. I'm going to talk a little bit about this, because this I got this from the Haemophilia.org UK site, and this was Dorothy, who was in her 80th decade when she got diagnosed, having a heart operation, and had such a big bleeding history, had most of her teeth out and bled for like 5 or 6 days afterwards. Because she was a woman, nobody kind of put 2 and 2 together, because women didn't bleed, or it must be the granulation tissue, or it must have just been one of those things, or whatever. It's amazing how many people have actually gone through quite extensive surgery or extensive bleeding. So I think this is about communication. And I think we're used in dentistry to taking a bleeding history, but we kind of see it as a barrier rather than as a facilitator to say, actually, this person's got a bleeding history, let's point them in the direction. So when we're asking people if we're going to take teeth out, for example, so there's 2 times we should take a bleeding history. One is before we do something invasive, and by invasive I mean lift forceps, perhaps lift a flap, put an implant in, crown lengthening, maybe really, periodontal surgery, for example. We need a bleeding history, and we often ask about bruising. Have you got family members, heavy periods, nosebleeds, bleeding after surgery, bleeding after childbirth, previous bleeding after dental extraction, cuts that don't stop bleeding after 5 minutes, or low iron. And anybody with 2 or more of those on a list has a really good chance of having an underlying bleeding history that needs to be encouraged to have it investigated. And that's what the haematologists are asking us to do. The haematologists want these patients diagnosed, because as soon as they're diagnosed, they can have a safe future going forward. There's often problems about people saying, well, will I be able to get insurance and all these kind of stuff? But von Willebrand's and the Irish Haemophilia Society, for example, very strong advocates to make sure people can still do their travel or whatever, but this means that people can have a safe future and probably a lot better quality of life. So I think the first thing to do when somebody has a bleed after we see them is to actually say this, or we're seeing somebody in front of us, we're scaling their teeth, and we're seeing more bleeding than we would expect for the amount of inflammation there is, for example. This is the time to say, I'm seeing much more bleeding than I would expect. You know, have you got a bleeding history? You know, is there anybody in your family? And ask those questions. And I think that then it makes people start to think themselves.
I think that again, it's supportive at this point rather than a blame thing. And we know we see bleeding. We know what bleeding to expect after a tooth is taken out. We know what bleeding to expect after a scaling. And classically, bleeding in haemophilia happens later on, because it's about the clotting factors. But classically in von Willebrand's, because it's a platelet disorder, that you see it straight away. You'll see more blood than you would expect. And I always comment and say, I'm seeing much more bleeding than I'd expect. Do you have any other bleeding issues? And go straight into that, not judgmental or whatever. So I would really encourage that to go forward, because I think that that can be the trigger to help somebody to address this bleeding, because this is the time when using a questionnaire or your own, if you decide to do your own bleeding history, you can start to explain to people who have perhaps a family history what is normal and what isn't normal. For example, it's not normal to be changing your sanitary towels every hour. And yet in some families, this is normal. It's not normal to be having bruises the size of, of a 10p coin or a €2 coin, for example. But the websites will do all of that. And there are so many self-tests for people. So how do we promote good oral health in these patients? We read in so many of the textbooks about bleeding gums. And it's really interesting, because this has been a big dilemma, and there's lots of information and misinformation that's been given to tell people how to actually look after their mouths and their gums. So let's get to the facts. The facts is that if we look at qualitative studies, there's a nice study from New Zealand that quite clearly tells us, in quite a large study, 2012, 8 years ago, that patients with bleeding disorders stop brushing their teeth in the presence of gingivitis, as they, in their study, found that they attributed the bleeding to their bleeding disorder. They thought their gums were bleeding because they had a bleeding disorder, so they stopped bleeding. They stopped using them, using a toothbrush. They may use mouthwashes. They may use cotton swabs, or they may just stop brushing. Certainly wouldn't think about using floss, for example. I did a qualitative study of a mixed group of both haemophilia and von Willebrand's, and they were very worried about where to go to a dentist. And often, the minute they went to get their teeth looked at or asked for them to be cleaned, they were refused care. This was a kind of vicious circle, because this led to more gingival problems, halitosis, leading them to cover their mouths in public, worried about loose teeth falling out. And they reported bleeding from their gums lasting for about 10 minutes sometimes. Didn't brush their teeth, and this then affect their food choices. They wouldn't eat an apple in public because there'd be blood on the apple. Caused social embarrassment, and affected, obviously, because of their halitosis or whatever, their relationships. So, do gums bleed because of the bleeding disorder? Well, the long and short of it is, no, they don't. But many medical professionals and patients, and possibly even dentists, either don't believe that or were taught differently. So I think what is absolutely definite is if somebody has gingivitis or gingival inflammation, the bleeding is going to be prolonged and more. But healthy, stippled, good quality gums don't bleed, even in a very severe bleeding disorder. Lots and lots of evidence for that out there. So if you or I or somebody had this amount of gingivitis, they'd see some bleeding. There's a famous advert, isn't it, that says, you know, if you see this bleeding, would you ignore it? Well, quite clearly, this group would ignore it. In fact, quite clearly, they would also possibly ignore this much bleeding after they've brushed their teeth, or think it's normal, or think it's part. If they're having heavy periods and nosebleeds 2 or 3 times a week, this is just nothing compared to what's happening from nose or whatever. In fact, this also quite clearly is sometimes ignored and seen as inevitable by this group. And this is where it starts to get difficult, because they don't seek care, thinking that, and so quite often we see periodontal disease quite advanced. So I'm just going to have a little look at some of the questions here that are coming. Let's just see. I've been asked by a patient to go as I found more bleeding than I felt I should for oral hygiene. I asked to get a blood test. I wasn't sure what to. I asked the patient to go to a GP. Yeah, you weren't sure what to do as her hygienist. I think if you found more bleeding than you felt, then in most cases, it's easy when you know somebody's got a disorder. You take all of the precautions. We'll talk about that. If it's happening for the first time, I would apply pressure. Pressure works extremely, extremely well to any bleeding sites. So gauze, also very cold things applied to the gums will actually stop bleeding. But if I'm seeing more than I would expect, then I wouldn't say go and have a blood test, because I would go more than that. And I would say, I would ask the bleeding questions, and I would say, I think you need to see a specialist hematologist, because a GP would check platelets or maybe even arrange for factor VIII or something, but they can't do the test. So what to tell your patient is, I'm seeing more bleeding than I expect. Have you got any other bleeding issues? If they haven't, then, you know, I would probably think about inflammation. But if there's ask any yeses to any of those other questions, I would say, you know what, I'm going to give you a website to have a look at, and I would suggest that you get your GP to refer you to the National Coagulation Centre to be tested for a variety of bleeding disorders that women can experience. That would be my answer to that question. Would I carry on? If there was a lot of bleeding and I wasn't able to stop it, then I would stop and I would put pressure on to that area. You can usually stop bleeding from the gums, but I certainly wouldn't do root debridement or something at that point. My next question, could a deficiency in vitamin D in a man be an indication of von Willebrand's disease? No, von Willebrand's disease is a deficiency of a clotting factor. But people with bleeding disorders, haemophilia, for example, who aren't having exercise or are sitting at home, for example, not exercising, not getting out in the sun, there's high incidences of osteoporosis, for example, and vitamin D deficiencies. So, but no, it's not caused by vitamin D. Is anyone having? And then the others are about Wi-Fi. So let's go on. Recently, in fact, just about to be published, there was a big European survey of about 408 patients with von Willebrand's. They had 70% of them reported significant bleeding from the gums, and it was the most common. After heavy periods, it was the most common site where women reported bleeding from the gums. So this picture at the bottom would be a similar picture of somebody, if following scaling, you're getting that sort of degree of bleeding and there isn't really generalized severe periodontitis, that's the sort of thing that I would look at and think there's quite a lot of bleeding, and ask my bleeding questions at that point. So the big question, is it inevitable that these 70% of women have got bleeding gums? You know, the national average is, or certainly average, we'd look at 50% over a life course, but 70% of women who could be bothered to answer a questionnaire sent to national member organisations. These will be the highest health literacy women that there's, and 70% of them. And if it is, so is it inevitable? Is it treatable? Well, a hygienist who I work with, very bright, Svetlana Anichuk, did a master's project specifically looking at gum bleeding in von Willebrand, so we could learn more about how to address this 70%. She did a study looking at gum bleeding in 36 people, men and women, with von Willebrands for her master's. And what she found was that people who reported having quite extensive gum bleeding actually described themselves as having good oral health. They went to the dentists. They didn't think they'd got any control over their bleeding gums. And interestingly, unlike the group from New Zealand, this group said they thought it was the way they were brushing their teeth. They were using too hard a brush, or they were using poor technique, or it was, so this was really interesting. They thought that they were causing it. Many of them attributed it just spontaneously to just happening, just like a nosebleed. But many of them also said, even if they went to the dentist, it was difficult to get their teeth clean. So we did thorough research into patients with gingivitis. So we took out the patients with periodontitis, and we went for those with gingival bleeding, with pockets of less than 4 millimeters. And we did a randomized controlled trial. We were just about to publish that. But we found 56 people with von Willebrand's. All of the inherited disorders are quite common in Ireland, and we're a national centre, so we were able to get 56 people with von Willebrand's who signed up for our study. We assessed their gum health using a variety of indices. One group got professional cleaning and an education oral hygiene intervention. The other one got a just the education part of it. We used some specific tools. We use a papillary bleeding indices. It's quite an unusual one to use for this, because this is basically where you use your probe and you actually just sweep through the mesial papilla to see and to score the bleeding. We use it specifically because we were going to use it as a motivational tool, but also because everything else in von Willebrand's disease is measured by the amount of bleeding, whether it be the blood flow from the nose or whatever. So we wanted to align with that, because this is how people with bleeding disorders measure their own bleeding. So we use the papillary bleeding index. So they're a typical example of somebody with gingivitis after having, and we would time how quickly the bleeding came and how many sites there were in the mouth. We then disclosed very carefully using plaque disclosing agents the plaque on the teeth, and did a thorough plaque score. Again, we equated this in a motivational way to a gym score, as if it was your fat index or your BMI or whatever, giving patients a score so they could actually start to score their plaque and they could see it themselves. And this was really interesting because we'd looked at this from a group in London who do a lot of work with very rare bleeding disorders where there's some really hemorrhagic gums. And they, to motivate their patients, always use plaque disclosing, not necessarily to show the amount of plaque, but to show the people where they needed to clear off, because people who were scared of touching their gums, they were seeing the plaque and they were very carefully removing the plaque and being gentle around their gums, but being really thorough. So we used this method. And Svetlana designed a 30-minute personalized but standardized oral hygiene intervention. Gave them scores for their bleeding indices, their plaque scores, and then their ritual was to brush their teeth twice a day using toothpaste, not less than 1,000 parts per million, leave the toothpaste on there. The big question is always, do we use a medium or a soft toothbrush? Because people are often told a soft toothbrush or even a very soft toothbrush. The idea here was to get them training so they could remove that plaque, because the plaque was causing the inflammation. So the answer to the question, which is always asked me, and I've got it here already, is it a soft or a medium toothbrush? Depends on the patient, depends on their dexterity, their technique, but they need matching with the correct toothbrush that is going to remove that plaque, so that it's actually based on a goal setting exercise, but small head. And we sent them home with disclosing tablets and a medium or soft toothbrushes. We also importantly got them to give them permission to do interdental cleaning. Again, sometimes a taboo and people are not sure what to advise, because sometimes it bleeds when patients are using interdental brushes. And this was the really, really killer thing that we did in this study. In the educational part was we gave patients permission to brush their teeth in the presence of blood. In fact, we told them blood was something they were used to seeing, and they would need to brush very carefully, very gently, using those disclosing tablets and the medium or soft brush with the right technique, and be confident. And it's interesting, we got them to keep a diary about doing the brushing. We got them to do a diary about how they were feeling about the brushing. They went off. I was blinded because I was doing the data collection, so I didn't see the intervention. That was purely our hygiene led. Probably quite skeptical, because these people had had bleeding from their gums for years and years. We sent them off for 6 weeks. Well, we cannot believe, in fact, we were surprised by the improvements. The 16 patients on personalised home care alone, you can see the reduction in bleeding sites. You can see some of them had over 30 bleeding sites, down to 0. We saw that the gingival index went absolutely down from, really poor quality gums down to pretty healthy looking gums. And that was really interesting, because these were really, really statistically significant results, and the plaque was related, the gingival index was related to the amount of plaque on the teeth. So the good news is, for you and for us, we can quite categorically say that it's safe to tell people to floss and use and brush in the presence of bleeding. In fact, we need you to be giving this message over, because it is this, I think, that is the difference. So a personalized, tailored regime clearly reduced and eliminated, and the bleeding was related not to the severity of their bleeding disorder, but it was absolutely related to the amount of plaque on their teeth. The women were absolutely delighted, amazed even, and extremely motivated. So we're just analysing whether it made any difference with people having a professional clean or not, or whether just the removal in these patients with gingivitis was enough with the education to do the job. So we can quite categorically tell you, for women with von Willebrand's disease, type 1 and 2, that's the common ones, healthy gums don't bleed. So we can and we should be advocating prevention and not just accepting the bleeding. So the guidance going forward, if it's straightforward to give people toothbrushing advice, but what about when patients need more thorough periodontal care, for example? And this is where we need to work with our interdisciplinary teams, because like Dorothy, she lost all of her teeth, had terrible bleeds afterwards, but she wasn't having care. She has not kept her teeth for older age, but now people are living longer with medical conditions. We need to make sure that we maintain their dentition for their general health, not only for their function, self-esteem, and all of the quality of life. So periodontal disease is the most common inflammatory disease. It affects 50% of the world's population, but we know in bleeding disorders, if gingivitis is untreated, we could be letting periodontal disease progress, accelerated tooth loss, and again, that's going to lead to surgery in patients with bleeding disorders. But the prevention and management of periodontal disease is not only focused on improving oral hygiene, we've talked about that, it's also about root surface debridement, and both processes can cause gingival bleeding. So how do we manage it? Well, it's very clear. We have a very clear traffic light system of when we need to consult with patients or when we need to get extra help. So all of the things like periodontal probing, infiltration injections, impressions, fissure sealants, examinations, all can be done with no special measures. The middle, and that's an interesting one because people are scared of periodontal probing, but it's perfectly acceptable and it's in all of the guidelines that you can do your 6-point pocket charting or your BPE or any of your basic periodontal examinations, and should be doing that because we need to be monitoring the patients. When it comes to subgingival scaling, it's a little bit more unclear because if somebody's not got great amounts of inflammation, subgingival scaling is also considered perfectly safe to do on patients with bleeding disorders. Root debridement by contrast is something which is a much bigger risk because you've often got inflammation there. So root debridement, we call a red procedure. Doesn't mean you can never do it. It just means that we need to take certain precautions. So what are we going to do? When I'm seeing any patients with periodontal disease or inflammation, before we treat them, we usually will advise them to take chlorhexidine for at least 1 to 2 weeks. We do this as well when we're taking teeth out because we know that inflamed tissue is much more likely to bleed. So we want to decrease our bacterial load and we want to decrease inflammation where possible. So for a 2-week period, I feel very confident to prescribe chlorhexidine gel, preferred gel, but spray or mouthwash or whatever, but I'm a gel person. Because we've got to think here, if patients have got a bleeding diagnosis, then they are often taking medication when they have their periods, or if they're suffering from nosebleeds or whatever, they're often taking tablets called tranexamic acid tablets. This is cyclocaprin, this is antifibrinolytic. And if we're going to do subgingival scaling and I'm worried about the bleeding, then I have no problem in liaising with the hematologist, or the patient can do it, and suggesting that they're on their tablets, starting the day before and continuing for a couple of days afterwards. Because what these antifibrinolytics do is they stabilize the clot, they stop it from being dissolved by the saliva. So we can put patients on tablets. We can, so that if we're going to see this sort of bleeding, that we can be also, the patients can crush those tablets up, or they can take a mouthwash. We use, and I'm unashamedly going to say Kian Exagel here because they're the only people that make this bioadhesive version of tranexamic acid. And what this and why it's useful to use any of these preparations is because saliva is known to dissolve clots. So anything that a patient or you can actually, after you've applied pressure to any bleeding sites, put either mouthwash or gel over there is going to mean the patient's confident and the clot is going to stay in place and we're not going to have any hemorrhaging happen. And in most protocols for patients with bleeding disorders, women with bleeding disorders, then antifibrinolytic acid therapy, usually tablets started before, and then topical tranexamic acid gel or mouthwash afterwards is the go-to protocol. This is the sort of thing that can very safely be done in primary care and with hygienists. We have our hygienist students coming in to the centre, or learning how to work in the presence of and using the mouthwashes, for example. And the tranexamic acid tablets are in the prescribing portfolio of dentists in Ireland. So, you know, that the patient can get themselves from their haematologist, or they can be prescribed. So, as I say, that tranexamic acid tablets start at least 4 hours for the procedure, and patients take 1 gram 3 times a day. Sometimes, if people are also nervous, I would say to them, treat a quadrant at a time and see how you go, so that, you know, you can apply a little bit of pressure, a little bit of gel, and then move on to the next one. Sometimes we apply vasoconstrictions with a local anesthetic with adrenaline, and topical measures. But all of this is there to counteract the saliva dissolving the clots. So here we have patients with advanced periodontal disease. I mean, such a tragedy when somebody with a bleeding disorder has dental neglect, or hasn't been in their care pathway, or is phobic. And we see a lot of dental anxiety in patients with bleeding disorders because they had perhaps bleeds when they were children, before they were diagnosed. So patients who are needing things like root debridement, extractions, ID blocks, all on the red traffic light system. These are the patients who need to be most definitely worked up by their haematology team first, before any of this treatment is provided. Once they're worked up with their team, they've been given a mixture. Some of them will be given DDAVP, which just basically gives them a boost of their own von Willebrand factor. Others are given an infusion of von Willebrand factor and some factor 8 with it. And that means when you're treating them, they can be treated as normal, because the bleeding won't be pronounced, because at that time, for a short, perhaps 7 or 8 hour period, their bleeding levels are, their factor levels are not low anymore. They're as normal, they're at normal or typical levels. So all of this means that when a patient has got a diagnosis, it is so simple, because you can work in partnership with haematologists. And we have, as I say, some of the best haematologists in the world working in Ireland, who are interested in women with bleeding disorders. So the way to work in partnership with them is with the patient, because nowadays it's a 3-way relationship. It's the dentist, it's the patient, and it's the haematologist. So the first thing, if anyone declares a bleeding disorder to you, is, even if they're a woman who says they are a carrier of haemophilia, you need to have confirmation of that from the team before you do anything, because we know that women who carry haemophilia can be bleeders as well. So it's fine to do your examination, your periodontal probing, perhaps a little bit of polishing, but if you're doing anything other with the gums, you need to have a confirmed diagnosis from that patient. Patients carry a disorder alert card. What will happen then is that remains stable. That level of bleeding disorder. It's not like people on anticoagulants where you have to have an INR every 4 weeks, or the day before you do something. This is a level that stays the same. So you only need to liaise with that haematologist once to get confirmation. Thereafter, if you're going to do something invasive, the patient will go to their haematologist and tell them what's going to be happening. You can give them a letter, or you can give the haematologist a ring. They are really happy to receive emails or letters about what you're planning to do. So if you've got anything on that amber list, or you've got anything on that red list, you need to liaise with the haematologist. They'll provide you with a detailed, that you'll provide them with a treatment plan. They will get the patient ready for you, so that when the patient's with you, you can quite confidently go forward and provide your root debridement, for example. time your appointment so that all you need to know is, what time shall I see this patient? To give them time to go to the haemophilia centre, to give them time to take their tablets or have the 4 hours after their tablets. But most important is to give the right advice, is to give the right advice about the importance of interdental cleaning, about the importance of using a proper toothbrush, about the importance of using good quality toothpaste with fluoride in it, about the importance of short courses of antibacterial chlorhexidine, for example, to reduce the load, so that you can actually help them achieve those healthy gums, which are going to mean they can eat in public, they can kiss their boyfriends, they don't have to cover their mouths, and what's more important, they're not having 10 minutes of bleeding into the sink every morning before they try and get out for work, which to me is unthinkable, but we have so much literature that that's what people are living with. So I'm going to sort of have a little look and see if they've got any questions, and I hope there's some coming. I hope you find that interesting. I work at the National Coagulation Centre in Ireland. Our centre provides every single patient with a bleeding disorder with a letter, which is specifically for their dental team. And it says, "Dear dental team, this patient has got a severe, mild, moderate, bleeding disorder." Their bleeding disorder is really less important as just the fact that you've got confirmation. It will say it is safe for you to do scaling, for you to do fillings, for you to do orthodontic, blah, blah, blah. Should you need to do root debridement, or should you need to do scaling, blah, 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 then please instruct the patient to take tranexamic acid tablets, or every patient has an individualized prescription. If you want to speak to us, you can phone or email the National Coagulation Centre, and we can give you one-to-one personal advice. During COVID, we've been doing it via telementoring. I've been doing a lot of telementoring of dentists and hygienists to give them the confidence to go forward and do the treatment that needs doing, because this is scary. If you're not used to it, I think we've read such a lot that we're scared to go ahead. But I think what we've got to realize is we're working with the patients. We work together to sort their gums out. They are so elated when, after several years of having bleeding gums, we can do something about it. Just as they are elated if they've had heavy periods, they've had a coil, or they've got their tranexamic acid tablets and they can start playing sport or living a decent life. So I think the biggest thing we can do is, if we see bleeding that we're not sure about, we alert the patient to it, so that the first time they have a heart operation or a gallbladder, or, as I say, they're not really at death's door. And this is the big role that we play in helping to get women the diagnosis that they deserve. So I thank you very much, and I can't see any absolute pressing questions here. Oh, yes, I have. Here we go. Is there Margaret MacDonald? Hello, Margaret. Has said, is there any link with undiagnosed bleeding disorders in women with intellectual disability? Margaret, it's a really, really good question, because yes, as in people with lots and lots of disabilities, they have lots of undiagnosed underlying conditions, and often it's because those patients, those people with intellectual disability, will not permit the blood tests, or they've had a struggle with blood tests, or they're not reporting bleeding, or that they're leading quite protected lives, so they're perhaps not doing the big sports that other people would be, or for example. So yes, there is undiagnosed bleeding disorders in people with intellectual disability, but there again, there are lots of diagnosed patients with bleeding disorders as well. I think that the thing is that I think that what I would like to say is that people with bleeding disorders don't need to be seen in a specialist centre. I think that quite often what happens is somebody gets a diagnosis that may say von Willebrand's, and automatically people think, oh my goodness, needs to go to a special centre. I think that We do a lot of work with dentists to support them, so you can see that patient even though they've got a bleeding disorder, and we can support you with that. But if they need surgery, then of course they come to a specialist centre. But if you're noticing patients who've got really bleeding gums with intellectual disability that have got good plaque levels, then it's a sign. What are their periods like? People don't ask questions like that of people with intellectual disability, but yes, we have. So it's going to be in 1% of people with intellectual disability, because that's the incidence in the population. That's the answer to that, I think. So follow it up. Any bleeding? Is there a higher incidence of gingivitis in patients with one due to genetics or fear of adequate oral hygiene? Kathy, there is most definitely a higher incidence of gingivitis, because we're seeing 70% of people with bleeding gums, and as we know, healthy gums don't bleed. It's multifactorial. It's from us as dentists being scared to provide the therapeutics that are required. It's patients being scared to brush their teeth in the presence of blood, and it's patients ignoring bleeding and not seeking treatment for it because they think it's their condition. So it's all about gently going through what I talked about earlier, giving people permission, using disclosing tablets so that they can very carefully and gently go around their mouth. Don't underplay how worried they are to do that, and start with just the brushing first. Introduce the interdental when they're ready. So people can't change their behaviors overnight, but with you supporting them, and especially in the time of COVID, where we can follow people up with phone calls, we can use motivational approaches to phone and say, how are you getting on? Are things getting better? Is anything worrying you? Do you want to ask me something? People need support just for that first 6 weeks. Get them to keep a brushing diary, give them motivational scores so that they're actually looking at how well they're doing. There's another thing here from Yvonne Macaulay, just saying thank you. Hello, Yvonne, how are you? What have we got here? Indre is asking me, so should a patient use chlorhexidine mouthwash 1-2 weeks prior to subgingival scaling? How about after the treatment? Well, I think that there is no doubt that inflamed tissue bleeds more, because the inflammation actually inhibits clotting. So anything which is going to reduce inflammation or reduce the bacterial load in plaque, which is causing inflammation, will, so I don't for all patients, but if I've got localized periodontitis and I want to, then I will often suggest chlorhexidine. Regarding chlorhexidine, I think that chlorhexidine with hyaluronic acid, I know it's another product, and unashamedly that periodontists are loving, is to accelerate healing. So after teeth come out, or if you've got, or if you've done some work and you need healing to happen, then I think that's also a good idea post-operatively. But for me, it's about reducing the inflammation before I work, whether I'm taking teeth out, whether we're doing root to bride, but whether we're doing subgingival scaling. But you don't need to. It's perfectly safe if you haven't got huge amounts of inflammation. No, crack on. And but the tranexamic acid is a very good if you're scared to do that. Could Kin Exogel help alleviate the stress of bleeding? I absolutely think it can. I think that patients, if they've got a comfort blanket that they can be confident in and say, just for the next 4 weeks, we are going to, I really want you to thoroughly brush your teeth. I want you to commit to it, and I can guarantee you will see difference. And yes, if you've got a particular bleeding site, if you've done a papillary bleeding index and you say that's where the bleeding is here, then get them to use the gel afterwards. It gives them confidence, and it will also stop the bleeding because it stops the it stops the saliva from dissolving the clots. So yeah, I do. We either put patients on the tablets or we give them the gel. If we've used the gel in the surgery, we give it to them to take home and use, and they like it. Why I like it is because it sticks to the gums. I think it could stick better, and I have talked to Kid about this, but it's a lot better than mouthwash. So can education alone provide improvement in this group? 100%. I can tell you via a randomized control trial, or let's say the T will be able to in precisely 2 weeks, because we're just about to do the statistics, but eyeballing the data says absolutely education alone is hugely significant, because in gingivitis, in periodontitis, we haven't got the study, but in gingivitis, pocketing less than 4 millimeters, absolutely education alone was miraculous. But the permission was to bleed, was to brush in the position of bleeding, and that's the big message. I think the thing that we don't do when we educate patients, we don't target things specifically for them. We need to give them the messages that motivate them or that they're worried about. But I think if we are doing motivational approaches, we need to commit to it, use our telemedicine, and follow people up with nudges and feedback and phone calls and diaries, because then we really will achieve change. This wasn't just telling people how to brush their teeth. This was a proper standardized motivational approach with follow-up. And yes, that did absolutely improve the gums beyond our dreams, really, and their dreams. I've got somebody else from Elizabeth Gonzalez. Hello, many thanks for the website. Could you talk about the haemophilia carriers? Yeah, so haemophilia is, if a woman is carrying haemophilia, she has a 50% chance of having a son with haemophilia. So she has 2 sons, one would have haemophilia, one wouldn't. And her daughters will be 50% chance of having a carrier. So carriers have a great big varying. They will vary from having near normal levels of factor VIII right down to having perhaps only 20% of what they should have. So 20% is enough to bleed if you're doing something like root debridement in really severe periodontal disease. It's also enough to bleed if you're taking a tooth out. It's enough to bleed if you're doing a wisdom tooth or an implant. So somebody with a carrier is always will be in touch with the haemophilia centre, because often they've got in touch with them because they've given birth to children, or they've got children who have got a bleeding disorder. So they're in touch with, but they usually neglect themselves. So I always, if I'm seeing a carrier, ask them to have confirmation of their levels if I'm doing any surgery. There's a big move towards carriers to redefine some of them of having mild haemophilia. So if you're doing surgery or anything invasive, subgingival scaling is going to be okay generally, but it's always good practice to know, and for those women themselves to start thinking about themselves rather than just the children they're carrying. So yeah, carriers, very, very interesting, very, very topical, and lots of research needs to be done on carriers, because there isn't lots of research of if they need hip replacements as they get older, if they need heart operations. And often they meet great barriers. The minute they say there's a carrier, they can't have a tattoo, or or they're not sure whether they can have this operation. So they sit in no man's land. So as with everything, especially in Ireland, it's very easy to get those patients' data, and they can ring up, or you can send a letter for confirmation to say, I'm a dentist or a hygienist, I want to provide care for this patient. Is it safe to go ahead? So the carriers are usually in touch. If they've got 30% factor, then they've got gingivitis, they're going to bleed more than we expect. Can brushing with a medium brush cause further recession of the gums? I'm not a hygienist, you could tell me better. It's all to do with technique. If someone's got poor technique, you put them with a softer brush, or you use them with a different type of brush. So it's about matching the person and the technique with the brush and the kit that they need. Some people have got good very good dexterous. I think everything that we teach should be task focused. Let's see their technique, let's watch them, especially when they've got a disability or low health literacy, for example, or we need to see them in action, and disclosing tablets is the way forward. Would I recommend chlorhexidine mouthwash for these patients? If they've got periodontal disease, a short course of PerioKin or something, absolutely, but only a short course, but not routinely. No, what they need is good oral hygiene. I've asked a patient to go as I found will bleed. Yes, we've had that. I think that might be all my question. Oh no, there's more coming. Have I got time? Are dental hygienists allowed to apply this gel? I believe so, yeah. I think patients can apply this gel, so it's topical. Yes, if you can apply whatever it's called, topical anesthetic, then I would think hygienists can do everything. We know that. We need hygienists to have much bigger scope of practice than they do, but yes, they can. And that's it, I think.
Brilliant, Alison. Yeah, I'm here loud and clear. Thanks a million, Alison. That was just fantastic, an absolute fountain of knowledge. I'd like to thank everyone for their participation this evening, but Alison, especially yourself, the time and effort you put in is amazing. I don't know how you juggle everything, but we really appreciate your valuable insights, and I'm sure that everyone has had some very powerful learnings from your presentation. So thank you very much. Over the coming weeks and months, webinars, e-detail and things like that will become an even more a bigger part of what we do here at PAMIX. So I hope you will all join us again on the next Kin Dental webinar. Your support during the challenging times is very much appreciated. So take care, everyone, and stay safe.
Okay.
Thank you.
Thank you. Thank you.
Bye, Alison.
I'd like to thank you for actually choosing this subject, because disability and medical complexes is often overlooked. So I think all credit to you guys for allowing me to talk about something that's often stigmatized or ignored. So thank you very much.
That's an absolute pleasure, Alison, and we'll have you back again for sure. Thank you.
Okay, bye.
Bye-bye.